Okay. Good morning, good evening, good night. Greetings, everybody from New York. It gives me great pleasure to call upon Dr. Sati Keswani to kick off the MWIA parallel event for CSW 65. And may I request those of you who are not speaking to kindly turn off your microphones so that we have bandwidth. And those of our attendees, kindly turn off your cameras so that we have bandwidth, except for those who are speaking. Thank you so much. Over to you, Dr. Keswani.
Good morning, good evening, as you said, good afternoon to everyone, and welcome to our CSW 65 celebration during the History Month for Women. And as you know, we celebrated our 100th celebration in New York 2 years ago, and MWIA was founded just 4 years before that, and but we continue to have recognition at the United Nations as a body representing at the ECOSOC, and Dr. Murthy and I have represented our organization. And without to do, I think I'd like to start the program. I'd like to call upon our President, Dr. Eleanor Nwabodino, President from Nigeria of MWIA.
Thank you so much, Dr. Sati Keswani. Greetings, everyone. And I would like to start by thanking in a very special way, Dr. Sati Keswani and Dr. Mini Murthy, our Secretary General, who have been steadfast and dedicated over the years in ensuring that MWIA has indelible footprints at the United Nations. I welcome our dedicated executive members and past EXCO who will be speaking on this panel themed Women Doctors, Champions of Global Equality. A warm welcome to attendees from around the world. Women doctors, yes, we are the champions. With COVID-19 making landfall, we have been the frontline workers alongside other frontliners, and our value can no longer be ignored. And our value must be recognized in the recovery process. When the Secretary General of the United Nations, Antonio Guterres, had a virtual town hall with civil society on the 6th of March for the Commission on the Status of Women, he said, and I quote, "Women need to be front and center of the pandemic recovery as a matter of economics, efficiency, effectiveness, and social resilience," end of quote. As champions, we must be visible and we must be audible. We as MWIA members are in the best position to lead the advocacy for equality. We absolutely have to move beyond the rhetoric, challenge the status quo, stand up and be counted when it matters, and celebrate one another when we triumph against the odds, and tell our stories of victory. But my dear friends, global equality cannot happen if women and girls are killed, maimed, and trapped in cycles of violence with visible and invisible hidden scars. Unable to attain their highest possible potential for human flourishing in dignity. I was educated by our Secretary General today about the meaning of the color red and how serendipitous that quite a few of us are wearing red in solidarity of Asian women who were targeted in the most heinous and cruel crimes recently in the United States. And this is happening all over the world. I celebrate our women doctors who have stood up to be counted as champions for a global treaty to end every form of violence against women and girls, as that is the pinnacle of commitment for attainment of global equality. In conclusion, I look forward to the intellectually stimulating presentations lined up for us today. Thank you and all the very best.
Thank you very much, Madam President. Our next speaker is going to be our very Dr. Padmani Murthy, our Secretary General, who I cannot thank enough for what she has been doing for the organization. Dr. Murthy.
Thank you so much, Dr. Keswani. You have been an amazing mentor to so many of us, and it's very hard to fill your shoes for anybody or even half your shoe. I just wanted to say hello to everybody from New York. It's wonderful to see so many people. And today is the International Day of Happiness, but I am sad, as a lot of us are, because the pandemic of hatred is raging alongside the COVID, and it is up to us as women physicians to put out the fires of this raging pandemic by supporting each other and, you know, lifting up each other and not criticizing and commenting everything we do, which sometimes is the norm, unfortunately. But in MWIA, we are really champions of global equity, and we work very hard. And I would be amiss if I did not give a big shout out to my colleagues, especially Bettina, to having worked with me through all the countless CSW recordings to get this webinar up and running. And also, I just want to put it there that I am keeping time. And as everybody knows, I'm like pretty strict as a moderator. So I will be posting a comment like, can we move on? The other thing is two of our vice presidents, Dr. Vivian Brown and Dr. Elizabeth Leichenstein, for some reason, due to a technical glitch, show up as guests, but the best part is you can speak. So I just want to reassure you both, it was not an oversight. It's a technical glitch because we went over this with a tooth and a comb. And last but not least, I just want to say that as women, we are strong, and in the spelling of a woman is a man. So it's high time the men realize that we are very much a part of it and we need to work together. So a woman, in my opinion, is a winner, and we are all winners. And thank you so much for everything you do in all these difficult times. And a big thank you to all our colleagues from all over the world who have joined us, not only from MWIA, but beyond. And thank you so much. So one of the good things about Zoom is at least we can see each other. Thank you. And I'm going to be keeping time. And I turn it now back to Dr. Sathi Keswani. Thank you.
Thank you very much, Professor Murthy. We start with our speakers, and the first speaker is Dr. Helen Goodyear, our treasurer of MWIA from the UK, and she is going to be speaking about the issues in the United Kingdom regarding health and well-being of women. Dr. Goodyear.
Thank you. So I'm going to talk about health and well-being and gender equality, and then a little bit about violence. We have in the UK what we call the gender pandemic gap. Over the past year, the domestic burden has become intolerable for many women who have taken on many roles such as teacher, cook, and cleaner, to name just some, as well as juggling full-time paid jobs. This is due to the 3 lockdowns in the UK, where schools have been closed and there's been very little support. The burden has fallen on women, and it has been said that we've gone back to the 1950s, expected to be housewives, but with additional responsibility. The retail and the hospitality sector, where there are a high number of women, has been hardest hit with job losses. 25,000 women lost their job with 2 companies alone, big names, Debenhams and Arcadia. We have rising women's unemployment rate, and many have had to give up work to look after children with loss of identity. Working mothers are 50% more likely than fathers to have lost their jobs. The government, in their Stay Safe, Stay Home campaign, showed some illustrations, one of a man relaxing on the sofa, and the others, women cleaning, homeschooling, and looking after children. I'm pleased to say this was rapidly withdrawn. Firms were required to produce a gender pay gap report by April 2021, but this has been postponed by 6 months. And in the UK, 80% of women earn less than men for exactly the same role. And we have lack of women in government and in businesses and in general in leadership. I'll now move to violence. The UK is shocked by the death of Sarah Everard, a 33-year-old woman who vanished from the streets of London at the beginning of March at 9:30 p.m. She was found murdered some days later in Kent. A policeman in the Corps who guard dignitaries is charged with abduction and murder. This has brought an outpouring of violence that women have suffered, and I will cover just some of these. Digital stalking, photos which have been put on social media and have been taken without consent, usually of women scantily clad on holiday in bikinis, and then an unknown man claiming that he had performed horrible sex acts with the victim. The police have closed such cases and not investigated them. In the UK, women who are raped, less than 3% in 2020 that had been reported to the police, and many are not reported, the perpetrator went on to be charged, so less than 3%. Abduction, where women have been forced into the car well of their cars, has been brushed off as carjacking. With COVID-19, we've had an increase in domestic violence. 31% of women at least have been affected, and 1 woman dies every 3 days from domestic violence. We have female genital mutilation. 66,000 women in the UK have had female genital mutilation. It was illegal in 1985, but we've had no convictions, and we have 23,000 girls at risk under the age of 15. I could go on, but what do we do about all of this as doctors? The key thing is support, ensuring that we do not miss victims in our day-to-day practice, identifying those who have been at risk of violence, supporting them, raising their cause, and as a medical profession, not tolerating any violence against women. Thank you.
Thank you, Dr. Goodyear. Our next speaker, and thank you for keeping the time. I'm impressed. Our next speaker is our past president, immediate past president from Germany, Dr. Bettina Flederer, who will speak about the introduction of the new database of violence against women of WHO.
Thank you very much, Sati, and thank you for giving me the opportunity to be part of this wonderful panel today. About 2 weeks ago, WHO, on behalf of the UN Interagency Working Group on Violence Against Women, published as brand new document, Violence Against Women Prevalence Estimates 2018, which is indeed timely, as the SDG target F5.2 is elimination of all forms of violence against women and girls in the public and private spheres, including trafficking and sexual and other types of exploitation. The report included studies from 161 countries on girls and women 15 years and older, and in a very standardized way. And these are the first comparable estimates across countries. What did we learn from those brand new data? Well, regarding global estimates on intimate partner violence, still, as Helen said before already, about 1 in 3 women experience at least once in their lifetime intimate partner physical and or sexual violence. That means that about more than 700 million of women and teenage girls are affected. Intimate partner violence hits early. 1 in 4 of all teenage girls between 15 and 19 years experienced physical and or sexual violence when relationships actually unfold. We have not been successfully able to protect our children and teenagers from abuse. Striking in this data is the difference in prevalence rate between settings. Lifetime prevalence is highest in the least developed countries, such as Southern Asia, Sub-Saharan Africa, and Oceania. But the lowest rates are still around 20 to 23% in the developed countries. National estimates can be found in the detailed report. I will share the link later in the chat box. Global estimates on non-partner violence indicates that the prevalence rate is highest in high-income regions and is between about 10 to 20%. The lowest rates are in the least developed countries of about 5%. However, one needs to keep in mind that this form of violence is in particularly stigmatized globally, and especially so in patriarchal societies where disclosure is associated with fear of blame and often grave repercussions for the victim. To summarize, it is depressing that these numbers are still so alarmingly high. We have not made much progress in the last 10 years, despite many words and good intentions, and despite the 2016, a global plan of action to strengthen the role of the health system in a multi-sectoral response was put in place. And why is this the case? There are many reasons, and I can only highlight a few. Reporting intimate partner violence or sexual violence, such for instance rape, still has a high social stigma and reporting rates are low. There are economic disparities, disadvantaged women, they are therefore more trapped in abusive relationships, and they still are often facing custody problems and receive not enough support in their national legal systems. Gender-based violence is rooted deeply in multiple and intersecting gender inequalities, not only in the least developed countries, but globally. Therefore, we have to tackle this underlying cause of violence against women with most urgency priority. And what are the existing challenges and the role of physicians? Well, psychological and economic intimate partner violence is still underreported or in the shadow, so to speak, because psychological violence cannot be seen. There are only mental scars and wounds. Medical doctors have a very important role as frontline responders to tackle psychological and economic abuse, because they are the first and often the only ones seeing the victims. What can be done? Implementing one-stop centers for victims and survivors, including health sector, police, social sector. As said before, girls experience violence at an early stage. We therefore need to open our eyes, and we have to intervene early. Develop school-based intervention programs to tackle gender inequities, transform gender norms, and medical doctors should be part of this. Train school teachers regarding gender equality and sexism, educate boys and girls, provide enough money for those school programs in a sustainable way, and we should have enough patients as donors not to terminate funding too early. Research has shown that 3 years are needed as a minimum to install change on a population level in a sustainable way. And install trusted health and wellness managers in community, enhance the awareness of healthcare providers, and last but not least, provide more timely data related to SDG 5.2, for instance, every 3 to 4 months online, without much ado, to be able to respond faster and more tailored. It is known that there is an escalation, in particular of intimate partner violence during COVID-19. And this is alarming because the number were already quite high globally before the pandemic. And I just learned at one parallel event during this year's CSW that 1,000 teenage girls in Peru became pregnant during the pandemic. To close, let us all work together to tackle all forms of violence against women and girls, to become these recommendations reality. No women and girls should live in fear to experience violence, and girls should be growing up knowing that they are all safe. Thank you.
Thank you very much, Dr. Flederer. Our third speaker is Dr. Edith Berger, the Vice President of MWIA Central Europe from Austria. The floor is yours, Edith. I remember our meeting with you in Vienna, very beautifully done.
Thank you. Thank you very much. Good morning to New York from Vienna. I've picked a very medical topic to talk about for my 5 minutes, which obviously has political implications as well. The issue I want to talk about is COVID-19 and pregnancy. Almost ignored by most of the official politicians is the fact that pregnant women, once infected with COVID-19, are at a high risk to have severe forms of the infection. Compared to non-pregnant women of the same age, many pregnant women don't get any symptoms at all. However, those who do get symptoms are at a very high risk to need intensive care. I could give you some numbers of the hospital in Vienna dealing with most of the COVID-19 infected pregnant women who show symptoms. Out of 90 women, pregnant women showing symptoms of COVID-19, 17 had to be admitted to the intensive care unit. One woman aged 31 died because of COVID-19 immediately after giving birth. Apart from the risk for the women, there is also a higher risk for the babies to have premature birth. So right now, we cannot recommend to vaccinate pregnant women due to a lack of data. But there can be other measures taken. Young women, in particular those who plan to get pregnant, should have priority access to vaccinations. We have many countries where we don't have enough vaccinations. Austria is one of those. So when it comes to priority lists, young women who plan to get pregnant should be top of the list. Pregnant women who are not vaccinated need protection. They should not be exposed to potentially infectious people at the workplace. For those who work in fields with a very high risk of infections, such as nurses or doctors, to name but a few, early maternity leave should be possible. At the moment, the fact that pregnant women belong to a high-risk group is not even common knowledge. So people have to be informed about that fact. They have to be encouraged to wear masks and keep the social distancing. That goes for the pregnant women, but also for those who deal with pregnant women. It is very encouraging that currently studies are going on, which will give us data about COVID vaccinations during pregnancy. So maybe in a few months, we will be able to vaccinate pregnant women because we have the data showing that this is safe. I want to bring awareness to this medical fact and its political implications. The medical fact that pregnant women are amongst a high-risk group when it comes to COVID-19 infections. And therefore, we need political awareness of that and reaction to that. Thank you very much for your attention.
Thank you for your presentation. Our fourth speaker is Dr. Elizabeth Lichtenstein, a VP from Northern Europe, Sweden. And she's going to be speaking about why women workers can't avoid the risks in a pandemic.
Thank you very much, Dr. Keswani, and more special thanks to Dr. Murphy, who has organized this so well. I will talk about why women workers can't avoid risks in a pandemic. And the facts that I'm about to present are from studies done by the Swedish Civil Contingents Agency and the Swedish Trade Union configuration. There's done a study that shows that women are better at keeping a social distance. They are better at washing their hands, they are better at using disinfectants, and they are better at avoiding unnecessary traveling. They don't say hello to each other by shaking hands or kissing on cheeks anymore since we have started the pandemic. And women are also better at avoiding social contacts than men are. They are also better at cutting down on physical shopping during the pandemic than men. And would you believe it? Women are better at shopping on the internet as well. Women are also more apt to use PPE when they need it. So what is important in a pandemic? Well, to prevent spreading disease, we need to keep a distance. We need to apply hygienic customs. We need to use PPE, and we don't leave the home, and absolutely we don't go to work when we are ill. Well, can everybody apply to these so-called simple rules? Well, women and men on the labor market have different circumstances according to where they work. And the pandemic has affected the blue-collar worker a lot more than the white-collar worker. White-collar workers have lots more possibilities to work from home. Sweden, would you believe it or not, has an extremely segregated labor market where women work in healthcare, they take care of the elderly, they work in childcare, and they work in schools, whereas men work within construction work, storerooms, transportation, and industry. And even if men have to leave a home to do their job, they can often maintain a physical distance to their co-workers and a third party. Whereas women working in different types of care and education cannot maintain a physical distance to their patients or other people needing their care. Studies show that 9 out of 10 blue-collar workers have gone to work during the pandemic. They cannot do their work from home. And 8 out of 10 working-class women work in professions that are in contact with other people, other than their co-workers. I will call these contact professions here on. 1/3 of women in contact professions have had little or no education regarding how to prevent spreading infections. 4 out of 10 women have had little or no access at all to PPE. 1/3 of the women considered that their employer had not done enough to help minimize risk of contagion. And 24% of women in contact professions said that cooperation between workers increased during the pandemic, which is a positive thing. During the pandemic, women's workload has increased much more than men's in Sweden, and mostly this is due to lack of personnel, whereas men's workload has sometimes decreased, mainly because they've lost their jobs during the. Well, when you're ill, most workers stay at home, 8 out of 10, but men were more apt than women to go to work, even if they had symptoms of infection. The largest reason to attend work, even if you were ill, was that no one else can do what you do. The second reason was economical. The lower the income you have, the less inclined you are to stay at home. Women worry on the whole much more about their own health than men do. And men were at more risk of losing their jobs and women at more risk of having their hours reduced. Both of these lead to less income. So what can we do as women doctors about this? Well, to start with, we have to make sure that everybody understands basic hygiene. We have to educate. We have to demand that personal protective equipment is used in all environments where contacts can't be avoided and that people have access to PPE. We also have to point out that women are at risk because of constructional circumstances, not because of their failure to follow guidelines. And as always, we have to raise our voices in media, at work, at home, everywhere. Thank you very much.
I appreciate your remarks, and I will go to the next speaker, who is going to be Dr. Antonella Visani, and she is going to speak about the domestic violence during lockdown in Italy.
Thank you so much, Dr. Satti, and good morning to everyone from Parma in Italy. With the onset of the epidemiological emergency from COVID-19 in the first month of 2020, specialized services immediately began to talk about a likely future increase in cases of violence against women in the home due to the greater risk of violence due to forced confinement and difficulties for victims living with the perpetrator to report and contact support services. 1522 is the toll-free number made available by the Department of Equal Opportunities to support and help victims of gender-based violence and stalking. It's a free number, guarantees anonymity, and covers various forms of violence for 24 hours a day and in 4 different languages beside Italian, English, French, Arabic, and Spanish. This helpline provides first aid information in the event of an emergency or useful information on the anti-violence services active at the local level to which victims of violence or other users can contact. The lockdown and quarantine have contributed to further increase the isolation of women and their difficulties in activating support networks. Due to the pandemic, hospital reception system for violence victims has been suspended and the refugee homes closed. Between March and June 2020, calls to the number 1522 were more than doubled. The phone calls were made above all to ask for help in case of violence and or stalking, to report cases of violence, and to obtain information on anti-violence services. Most of the calls came from women of Italian nationality, heterosexual and without disabilities. In most cases, violence did not appear to be a sporadic episode, but concerned repeated behavior over time. 74% said that the violence lasted for years, more than in the same period of 2019, and 18% said which has been going for months. The violence reported by the victims was mostly physical and psychological, with a large number including sexual. Despite the increasing call to 1522, most of the victims did not report the violence suffered. The reasons for not reporting were related to the negative consequences in the family context, to the general fear, to the fear of a violent reaction from the perpetrator, or to the lack of trust in the forces of order. Even when violence was reported, more than 40% of the victims returned to the offender. On the other hand, the number of women killed by partner has decreased, probably due to the murderer's inability to escape from the place of murder due to the lockdown. In the same way, during the lockdown period, we observed a general decrease in all crimes, thieves, murders, and more. But at the end of the lockdown, the number of women killed has rapidly increased. In the first 2 months of 2021, when the restrictive measure has been eased, 13 women were killed by the partner. In conclusion, the increase in domestic violence has added to economic and social problems and has contributed to making it more difficult for women to face the restriction induced by pandemic. Thank you for your attention.
Thank you, Antonella, for your remarks. Our next speaker is unable to join us, Dr. Magda Sampiao, the VP of Latin America, Brazil. So I will go to the following speaker on our program, Dr. Vivian Brown, and she will speak about HPV and the 6 things you need to know. Dr. Vivian.
Thank you so much, Dr. Kasani, and thank you, Dr. Murthy, for organizing such an important event. I wanted to talk very briefly about HPV disease, and that is because we all know that cancer won't wait. Cancer won't wait for COVID to finish. Cancer won't wait for the immunizations. Cancer won't wait for this pandemic to be done. In 2018, the World Health Organization had a call to action, and this call to action was repeated in November 2020. What the World Health Organization said is that cervical cancer is one of the most preventable and treatable forms of cancer as long as it is prevented with HPV vaccination, detected early and managed efficiently. Prevention and early treatment are highly cost effective. However, cervical cancer remains one of the gravest threats to women's lives, and globally, 1 woman dies of cervical cancer every 2 minutes. This suffering is unacceptable and cannot continue. We know that elimination is within reach. HPV is the most commonly sexually transmitted disease in the world, and it can affect anyone, woman or man, at any age once they're sexually active. It's highly contagious. There's many subtypes of HPV causing warts, cancers, and precancers, and the way to protect yourself is with vaccine. So yes, while we encourage limiting partners, using condoms, and not smoking, vaccination is the '1 thing we can do to protect each other and to protect ourselves. Well, the World Health Organization gave us targets for 2030. And those targets include 90% of girls being vaccinated by age 15, 70% of women being screened with an HPV test between ages 35 and 45, and then managed appropriately. And that would aim for a 30% reduction in mortality from cervical cancer. These targets are manageable. These targets are targets we can reach, and we are working towards eliminating cervical cancer as an organization and as a country. So what has MWIA done? MWIA has partnered, and we've partnered with the Cervical Cancer Action for Elimination group. This is a global group trying to teach about cervical cancer throughout the world. MWIA has now partnered with Gavi to support vaccination and immunization in lower income countries. And what we are aiming for is we are aiming to have a celebration as we reach the point of less than 4 per 100,000 women not having cervical cancer. That then becomes the number that is the target, so that is no longer a public health emergency. Australia has already made this announcement, and Canada is working very hard to reach this goal as well. Australia has said by 2036, I believe, they will have less than 4 per 100,000 cases. So in Canada, we do have a strategy for cervical cancer elimination. We do have a number of areas where we're advocating for elimination. And what we've started in Canada in 2017 was a week for education. And that way the public understands what HPV vaccination and cervical cancer elimination is all about. In the US, they've now started a week as well. And I believe India and Taiwan have also started weeks for HPV advocacy and education. So how can you help? What can you do? I think by sharing the developments with your governments and conveying the sense that we need a growing coalition of civil society in support of the elimination agenda is very important. This goes across different health fields. This goes across geographies. This goes from communities to global organizations. By building your own regional and national coalitions, you can advocate in your community, you can advocate collectively. And there is support for this, as there are many global institutions and organizations. We would encourage that you press for head of state support and press for a national commitment to eliminate cervical cancer, because indeed, cancer won't wait. Thank you so much.
Dr. Keswani, you're on mute. Dr. Vivian Brown has finished. Thank you. Next speaker. You're on mute. Dr. Keswani, please unmute yourself. You're on mute.
Okay, unmuted. I was trying to introduce the next speaker. Is Dr. Sadia Christine, and she is from the near and East Africa, Kenya. I don't have your topic of, you may introduce your topic, please. Dr. Sadia. What's happened?
Thank you very much. Sorry, I joined colleagues. I joined in late because of connectivity issues. Thanks, Helen, for sending the link and which has managed me to join. I will take a few minutes to talk on this topic that I would like to address. And I would like to address the maintenance of essential health services during the COVID pandemic. In the region, and particularly in Kenya, we were challenged with the maintenance of essential healthcare services. When we started with the containment measures, the lockdowns, women could not access, and therefore the maternal, child, and health programs went down, family planning issues. I also would like to appreciate very much Vivian, who has talked about HPV, because in that context, those who are having chronic illnesses and those who are already on regimes like HIV, medication, PMTCT, we found that we could not sustain those services in the beginning of the pandemic. We had to figure out how then we again kickstart those processes. So that was a challenge. And I think because of our weak health system, mainly in the region where I am, I think that is something that in future, as we do resilience planning and as we are looking sustainable financing, is something that we need to pay attention to. Because when a pandemic or a crisis like this happens, it weakens. And therefore, we also noted that a human resource for health were moved from those areas where women were being served, and they were moved to respond to the COVID. That means women were left bare. With that in mind, we also, with the containment measures, saw a rise in gender-based violence, and we experienced quite many. We experienced domestic violence, particularly, and sexual gender-based violence. It moved from ranges, age groups, which are many, but particularly young girls were affected. And in effect, therefore, we have had a surge in unplanned pregnancies or teen pregnancies, which we are now dealing with. The government, the presidential has, and the president has already put a team in place, a technical team in place to give strategies, but also we are investigating because the judicial system were not very robust. We are now working on plans that have an end-to-end service to women during this kind of pregnancies. What did we learn? We learned a few things. We had some innovation where women came together and they got an ambulance service that would take women to deliver in places where we had women doctors. So that has been something that we are very proud of, that has gotten a presidential acclamation. So because of the time, I wouldn't want to take more. I know I have very little time. But in terms of the region, we are looking at regional collaboration because I'm working with reproductive health as an advisor in the WHO African region. So the region is looking at itself on how to ameliorate some of these problems. And therefore, we are looking at building back better so that when the pandemic hits, or as we are going through this pandemic, the resilience and strengthening the health system for women to get all the services that they would require. And our immunization programs were affected. In Kenya, we already had HPV immunization program going on. It was affected, and a lot more. What we have also noticed that we had an upsurge of stillbirths within our hospital. So I would like just to give you a highlight of what happened. I know what happened in Kenya may also be the same like has happened in the other region, but we are working with a UN women at the regional level, at the AU level. We have also talked to Economic Commission for Africa and WHO. We are coming up with a collaboration where we can have a regional platform where these issues can be addressed. It was good for us because we managed to do a gender spin to what the issues are.
Dr. Sadia, I'm sorry to interrupt you, but your time is over. So do conclude, please. Thank you.
Yes, I was at the point where I was concluding. We are looking at the regional initiative. And even as we take our regional meeting next week, these are some of the issues that we will discuss. Thank you very much. And over. I appreciate that.
Thank you, Dr. Christine, for your remarks. Next on the program is Dr. Mandakini Meg, who is unable to be with us because of a family emergency. However, Dr. Murthy will present her remarks. Dr. Murthy.
Thank you so much, Dr. Keswani. Unfortunately, Dr. Mandakini Meg is admitted in the hospital with COVID, but he's doing a lot better. She actually did a video message with me last night, and she and her husband, who both got COVID after being vaccinated, are much better. They are on IV antibiotics. She conveys her sincere regrets, but she and Dr. Usha Saraya have sent me the comments to be read on their behalf. So this is Dr. Meg is Vice President for Central Asia, which comprises of India and Thailand. And Dr. Meg, VP Central Asia, has been working on the impact of NCDs on women's health. She has given talks on the subject to emphasize how to reduce the disability and deaths in the affected patients, especially during COVID, and some of the key barriers for Central Asian women with NCDs are economic barriers, socio-cultural barriers, monetary barriers, geographical barriers, and access to healthcare, so health system barriers. And unfortunately, India, the cervical cancer rate is 96,922. In Thailand, the statistics of breast cancer are 22.8%, that is 22,158. Colorectal cancer is 10.7%, that's 10,443. Cancer of the uterus is 9.4%, that is 9,158. Malaysia, breast cancer cases, 8,418. Again, colorectal cancer, 3,057. Ovarian cancer, 1,836. And uterine cancer, 7.2. Pakistan, breast cancer, 25,928. Cancer cervix is 5,008. Ovarian cancer, 4,326. Bangladesh, the only data which was sent is cervical cancer, 8,068. So one of the main goals of the Association of Medical Women in India, which has 3 branches in Nagpur, Calcutta, and Mumbai, has been elimination and control of cervical cancer, and to meet the SDG goal of reducing mortality due to cancer has been promoted by all the branches of AMWI. And because of this, and they also have a colposcopic clinic, and Bettina and myself had the opportunity of seeing this colposcopic clinic when we went to India for a meeting, and they have been doing amazing work in Mumbai. And as a result of this, they have a program called Unsung Heroes, and Dr. Usha Saraya and Dr. Radhika Joshi have received awards in recognition for working on this effort. And also the other thing is the Unsung Heroes. This is really nice because they're also empowering women, promoting excellence and leadership, and mentoring younger women. And this program is spearheaded during the COVID by Dr. Yamini Alsi, the current president of AMWI, and Dr. Nalini Kurve, the honorary secretary of AMWI. And the other thing is they have been having a lot of webinars, keeping in touch. And some of us from AMWA had the privilege of participating in some webinars. So there's been an active exchange of information and also sharing and generally boosting up everybody's morale during COVID. And the last point, which was sent to me, is International Women's Day was celebrated recently with a week-long program, again on early detection of breast and cervical cancer in women at the Kama Hospital, where they have this amazing cytology clinic, which at present is headed by Dr. Usha Saraya and her dedicated team. Dr. Meg and a lot of the younger doctors are being mentored, and also the other staff of the cytology clinic, which is at Kama Hospital in Mumbai, with which Medical Women's International Association has had a very long-standing relationship through AMWI. Thank you so much, Dr. Keswani, for giving me the opportunity, and I think I kept to time. Thank you again, Dr. Saraya, who is on the call, and also just a shout out to Drs. Keswani and Dr. Saraya, who have been MWIA members for half a century, and thank you so much for mentoring so many of us. And on behalf of MWIA and myself personally, Dr. Meg, speedy recovery, and thank you for your dedication in sending this message. Thank you all. Back to you, Dr. Keswani.
Thank you so much, Dr. Murthy. I was happy to hear all about going on in our country of origin. Our next speaker is Dr. Desiree Yap, and she is from Australia and is our Vice President of the Western Pacific region. And she's going to be speaking on the gender equity in medicine. Dr. Yap.
Thank you, Dr. Keswani. Good evening, good morning, good afternoon, everybody,
Yes.
and thank you for inviting me to speak. The MWIA Western Pacific region is made up of 8 member nations: Australia, China, Hong Kong, Korea, Japan, Mongolia, the Philippines, Taiwan, and we have individual members in New Zealand. There are 5 areas I'd like to talk about today as to how we in the Western Pacific region are champions of global equity. Firstly, there's the importance of gender equality in medicine. Medical women's organisations have been campaigning for gender equality since their inceptions. In fact, this was the reason for the creation of our organisations. In Victoria, my home state, our medical women's organisation was founded in 1896 and joined MWIA at its inception in 1919, and our national body was formed in 1927. We are still campaigning. Each and every one of our member nations has a similar story. In 2019, the issue gained international attention with The Lancet publishing a series of articles on gender in medicine. However, we still have a long way to go. In addition to our individually mandated missions, member nations have suggested or undertaken many specific projects in this area. For example, Japan has had the issue of gendered standards of admission to medical schools. Korea has proposed a project looking at sexual violence in medical facilities. The second issue is the importance of considering women's health independent of a woman's reproductive role. There are many papers presented, including by various United Nations and WHO bodies, regarding the problems associated with addressing the needs of women conceptually and practically through the traditional lens of maternal and child health. That is, women are considered only in the context of being a means in the process of reproduction and as targets in the process of fertility control. Women as humans with specific physiological and health needs are not placed in the centre of discourse, processes and activities. Attention is primarily focused on their roles in reproduction. Again, our member nations have worked or are working or thinking about issues like the long-term survivors of childhood sexual assault, supporting a refuge for children rescued from the porn industry, considering or addressing health issues for female migrant workers in cities, thinking about the extra responsibilities placed on women doctors with respect to managing ageing families and anyone sick in the family. And of course, we've already spoken about the differential effects of COVID-19 pandemic on women. Thirdly, there's the impact of gynecological disease on women's capacity to fully participate in society. American women spent $3 billion on sanitary protection in 2014. In June 2019, Cervical and the BMJ presented a study regarding the productivity loss caused by menstruation-related symptoms. 81% of women reported presenteeism, that is, productivity loss whilst present at work or school. Overall, total lost productivity in their study amounted to 9 days off per year, and productivity was substandard on 23 days per year. Think of the economic implications. We all know about the importance of girls' educations. We all know about the gender disparity in education. We all know that menstruation is one of the many factors keeping girls out of school. Activism around these kind of issues is important to the member nations of the Western Pacific region. Fourthly, there's the impact of gender-blind approach to medical care, in particular with respect to the allocation of health resources and gynecological care. For over 20 years, we medical women in particular have been talking about the importance of considering gender differences in medicine. This is essential if we are to improve the efficiency and effectiveness of health service delivery and practice. The failure to acknowledge that men and women have different health needs not only harms our female patients, but threatens the success of key health goals. We know, for example, about the increased risk of mortality for women having AMIs because their symptoms are dismissed. Many diseases and treatment outcomes are different depending on gender. Unexamined, this leads to inappropriate management programs and funding. We in the Western Pacific region continue to advocate, lobby and educate our patients, peers and our policymakers on this subject. Gender sensitivity must be a consideration in all projects and undertakings in all areas of society and must be a criterion for all government funding. Lastly, there's the importance of effective policy and advocacy in bringing about equality. Sadly, Australia is also a case study on this issue. On March 15th, there was a nationwide March for Justice demonstrating in response to several allegations of sexual violence, including allegations of a rape in a minister's office in our National Parliament House, no less. Despite the involvement of 100,000 women, both our Prime Minister and Minister for Women declined to personally accept a petition advocating for justice with 100,000 signatures from the event organisers, and those protesting peacefully outside had wanted to personally pass over this petition. We are a democratic, high-income country, yet here we are still. In conclusion, there are sadly so many other areas of importance to women and equality, family violence, e-safety, misogyny in all its forms, and our members are working on them. Western Pacific region members are all actively working towards overcoming gender-related differences in health and healthcare between women and men, girls and boys throughout the world. Women's rights are human rights. Thank you for your attention.
Thank you very much, Dr. Yap, for keeping the time as well. Here we are at 8:30, and our last speaker is Dr. Shelley Ross, our past president of MWIA, plus she is the immediate past Secretary General of our organization, Dr. Shelley Ross.
Thank you, Dr. Keswani. The 65th session of CSW is focusing on the priority themes of women's full and effective participation and decision-making in public life, as well as the elimination of violence for achieving gender equality and the empowerment of all women and girls. This parallel event is focused on the topic of violence against women, as MWIA has done considerable work in this area, including writing an online manual and conducting workshops to train the membership. The COVID-19 pandemic has turned the world upside down. In so many different ways, women have been more adversely affected than men. Many of the jobs women do are unskilled and low paying, but frontline, requiring physical contact and proximity to others. Economic hardship has occurred because many of these jobs were the first to go. If the jobs remain, the women are at risk of infection due to lack of hygiene education and availability of PPE. Women have been forced to stay home to assume the major burden of childcare. With schools being closed, they have also had to provide homeschooling with endless hours of virtual instruction to supervise. Being out of the workforce and at home, violence against women has risen so significantly that it's been called the silent pandemic accompanying COVID. WHO has recently launched its new database from 161 countries in areas focusing on intimate partner violence and non-partner sexual violence. We have heard how this silent pandemic has occurred during lockdown in Italy and how the world has been rocked by the violent death of Sarah Everard in the UK by a police officer, no less. We have heard how women's health is more than their reproductive organs, yet allocation of resources and priorities for women's health is not equitable. There are a variety of opinions as to whether or not pregnant women should receive the COVID vaccine. Frontline health workers in the emergency department and ICU were top of the list to receive the COVID vaccine. Most of the workforce looking after laboring women are women, and yet with all the droplet potential with a woman in labor, they were not on the priority list for the vaccine. COVID has disrupted childhood immunizations, including the HPV vaccine, which was school-based. We have seen that the countries led by women have done better than those led by men, felt to be due to quicker lockdown, quicker decision-making, and clearer communication. My home country of Canada has stood out due to the number of women public health officers leading the pandemic work. It is now 25 years since the Beijing Platform of Action was launched at the historic Fourth World Conference on Women. It was at Beijing and in Cairo at the International Conference on Population and Development the previous year that gender equality and the empowerment of women were identified as essential to make progress. Then followed the Millennium Development Goals in 2000 with targets for 2015 to get us halfway. MDG 3 talked about gender equality and the empowerment of women. Then followed the Sustainable Development Goals, which are designed to finish the job to get to zero on 12 targets by 2030. SDG 5 talks about gender equality. Despite the Beijing commitments to take bold action on gender equality, progress and implementation has been slow. No country to date has achieved gender equality. With COVID, so many of the gains in women's rights, equality and empowerment have been lost in 1 year. As we head into the post-COVID era, it is the duty of women to regain these losses quickly, rather than waiting another 25 years to do so. UN Women is convening the Gender Equality Forum that starts in Mexico this month and ends in France in June. Its aim is for concrete, transformative commitments for gender equality. MWIA's membership is women physicians around the world who are well suited to the leadership roles necessary to regain and advance women's equality. Whether it be in gender equality, eliminating violence against women, or empowering women, MWIA will do its part. Can we count on you to do your part as well? Thank you, Dr. Keswani.
Thank you so much for that beautiful summation, Dr. Ross. Now our program ends as far as the speakers are concerned, and we are open for questions and answers for, I think we will have about 25 minutes. Am I right, Dr. Murthy?
We have actually less than that. Yeah, about 24. And then we have, vote of thanks, and then we sum up because at 9 o'clock, the platform closes automatically. Thank you, Dr. Keswani.
Okay. As a moderator, I will take the prerogative of asking the first question. And it is to Dr. Edith Strasberger regarding COVID and pregnancy.
Yes.
Hello, Dr. Edith.
What's the question?
Yes, the question is, in the United States, we are beginning to vaccinate women who are pregnant.
Mm-hmm.
And you had said that you were waiting for the data to be completed.
Mm-hmm.
In your case?
Yeah, thank you very much. I think in Europe, we have quite strict regulations on who we can vaccinate and whom not. Mm-hmm. We are looking at the US in that case. We know that BioNTech Pfizer currently is doing a study with pregnant women. Maybe this is what's going on in the US right now. And as soon as we have data, which basically means that first babies are born of those who were vaccinated during the pregnancy, we plan to start with vaccinating pregnant women. I think it will really be highly beneficial for those women.
Thank you very much.
Dr. Keswani, can I just add to something what Dr. Strasberger said?
Yes.
Yes. Thank you so much, Edith. I just want to say that in addition now, Moderna is starting trials on young children also. So we're all eagerly waiting. There are people who bash, who are again vaccine opponents, but as physicians, scientists, and public health professionals, we know that vaccines are some of the best tools to address infectious diseases. So we wait and watch. And thank you so much for talking about COVID and pregnancy. Back to you, Dr. Keswani. Thank you for giving me the opportunity.
No, not at all. Any other questions from any of the speakers or those participants?
Dr. Keswani, I see on the chat from one of our male colleagues, Dr. Sifine from Nigeria. Sifine, who's a colleague with me, a respected colleague and friend on the executive committee of the Global Executive Committee. We work with the DGC. Sifine, if you're there, could you please make your intervention, what you posted on the chat? Thank you.
I see two hands also, Betty and Dr. Gabriela. Hello. We will wait for you to be called. Go ahead.
Thank you so much. This is Dr. Sifine from Nigeria. Thank you, Padini, for the recognition. I'll be following up throughout this conference. I'm one of the people that support gender issues. I'm a proud father of 3 beautiful girls, a lovely wife, and a lot of sisters. I want them to share gender equality with men. With regards to what I posted about cervical cancer, the program is still on the infantile stage in Nigeria, and a lot of organizations are making efforts. By June this year, we are vaccinating about 2,000 male and female between 9 to 14 years. And also, we are providing subsidized cervical screening for women. It's quite expensive in Nigeria. We've reduced the price. Many women now have access to the services. Also, I want us to be treating domestic violence and intimate partner violence as a mental health issue. It's a psychological problem for somebody to beat any woman. And the moment we start recognizing it as a mental health issue, it will help to classify the people involved in such bad practices. Also, another problem we are having in Nigeria is that another African country is that we need a rescue homes. Most women are in their marriage because they have nowhere to go. They are not empowered. They are very poor to sustain themselves. And we need a rescue homes in the country to really rescue most people in a very toxic marriage. Thank you so much.
Well, thank you for your question. I'll go to the next question, which is Dr. Betty Agala. I see your hand is raised. Go ahead and speak.
Good afternoon, everyone. I'm very happy to be here. I just wanted to know what the global treaty is on ending violence against women and girls. Thanks to everyone for the great presentation. They've been awesome. I've learned so much. So if the MWIA president can help me to, in a few minutes, expatiate on what the global treaty is on violence against women and girls. Thank you.
Thank you. Thank you. The next question comes from Dr. Gabriela from Down Under. Hello, how are you?
Do you want that last speaker's question answered first before I ask mine?
You want me to call upon the...
No, my question is, the last person asked a question. I'm wondering whether you're going to have it answered before I ask my question.
Would you like me to go ahead and answer the question that was posed to me, Dr. Keswani?
Yes, yes, please.
All right. The question was to shed more light on the global treaty to end violence against women and girls. You know, it has been painful for me to listen to the accounts from our colleagues today about the very, I would call them obscene and obnoxious acts of criminality and cruelty from the UK and what's happening in the United States. You know, Australia, rape, you know, at the highest level. And, you know, the violence that's targeted, you know, femicide targeted at women and girls. Time has come for us to have a concerted effort, a global effort. I have to say, for example, Europe has the Istanbul Convention. We have the Palom de Barra in Latin America. In Africa, we have the Maputo Protocol. Those are good regional conventions. But unless and until we have a global effort, it'll be patchy at best. I'll give a very quick example. We have a global treaty for tobacco. That means wherever you are in the world, you board an aircraft, there will be no smoking, because nation states have come together with one voice, and there is a global treaty. As it stands now, the regional treaties put together serve only 25% of females on Earth. What are the essentials of the global treaty to end violence? You need to have good laws. Laws are not the be all and end all in and of themselves. But if you don't have a law, then you can't start. We need training and accountability of people like ourselves. Can you believe that some of our colleagues do not recognize when violence walks into their consulting rooms? So we need our colleagues trained. We need judges, police, all those who respond trained. We need services like shelters and economic empowerment. We need prevention education for our men and boys, girls and women about respecting one another. And we need dedicated and targeted funding. That's what you have in a global treaty. Our role as civil society is to advocate with heads of governments, because it's heads of governments that draft and call and, you know, ratify treaties. And that's the only way to go. We do have a convention on discrimination called CEDAW. Do you know that CEDAW was drafted 40 years ago and the word violence was left out of CEDAW on purpose? So it's great for discrimination, but not good for violence. They've tried to retrofit violence into CEDAW with recommendations, but a recommendation is a recommendation is a recommendation. It is not legally binding. So you and I, everybody on this call, can work to talk to your government. Let's have a call for a global treaty to end violence against women. As I always say, elbows locked, we can get to the finishing line together. I'll put a website and you can get more information from me. I don't want to take up more time. Thanks for listening.
Thank you, Dr. Eleanor. All right, I see Dr. Gabriela Casper. Go ahead, your question.
Thank you very much. First of all, I'd like to thank all the speakers. I think the quality of your presentation is all of them are absolutely outstanding. And I'm terribly disappointed there are only 38 participants. There should be at least 38,000 participants listening to you. But my question is not a loaded question. I really don't know the answer to this. I very much appreciate that a lack of menstrual hygiene products is horrifically stopping girls across the road from going to school. So it's a very important area. What I don't understand is in Australia, a lot of our young girls are using menstrual cups. And I don't know whether the rest of you have menstrual cups in your country, but they're small little plastic cups that they put in the vagina. They hold 25 to 30 mils of blood. They take them out, wash them, put them back in. So number one, they are very cheap. But number two, they're fabulous for the sustainability of the environment. And my question is, I don't understand, why aren't they used more in low-income countries? And I generally don't know the answer to the question.
Dr. Keswani, I'd like to answer Dr. Casper. In the United States, we do use these cups you talked about, which we call Diva cups. When
Yes.
Amber, a couple of years ago, during the earthquake in Nepal, and Amber, we are working with a lot of other countries too, and some first ladies. The challenge with sending something like the Diva cup, which you talked about, is very useful. But if you don't have water, how are you going to rinse out those cups if you don't have clean water? So one of the things which dissuaded us from sending the the cups, as we call them here, the Diva cups, to Nepal was this challenge. So I just wanted to add that even though this is there, it depends on the environment and on the circumstances there and whether they have running water to send these cups. So that is the downside of it. Thank you, Dr. Keswani. Thank you, Dr. Casper, for that intervention.
Can I just answer too, if I may? So the cups are usually silicone, not plastic. But I think the other thing that needs to be considered is that not all cultures are comfortable with intravaginal insertion of a device, and that we have to be very careful as women telling other women what to do without firstly checking on the cultural appropriateness. I agree, I think they're a sustainable device, but I know that there are many cultures who feel extremely strongly about the insertion of menstrual tampons or cups into the vagina.
Thank you. If you allow me, the moderator, I think I just would like to weigh in on the cup issue. Like my colleagues have said, Professor Murphy and Des, about the environment. I think sometimes we use the cup and we introduce more infection and more harm, and it leads to fertility. Some of the studies that particularly in the sub-African region. So I think for human dignity, whatever that we recommend from other areas should be something that will not cause no harm. So I just would like to add that to the debate. Thank you very much. Over.
May I make a comment about what has been discussed? Dr. Murthy, I'd like to say a few words about the cup. Hello, can you hear me?
Yes, please go ahead. We can. Thank you.
Okay. I do understand Dr. Casper's idea about using the cups. However, as you heard the comments from our other speakers, that yes, depending on the culture and where it is supposed to be, the Western culture may accept it because they're already using tampons now, but certainly not on the others. I still see some hands. There's one, Dr. from MWIA National, go ahead.
Thank you so much, Dr. Sati. It's so good to see you. Remember, we visited Salzburg together in 2016. I just want to inform you that in Nigeria, one of the motivators for gender-based violence is rituals in order to be able to become rich. And so they send people to molest and assault women. And in Nigeria, in February, we had a case of a 6-year-old girl whose perineum was completely scraped off because a rich man needed it to carry out, a man needed it to carry out a ritual to become rich. And he was going to pay 500,000 naira to whoever could get him the perineum of a virgin girl. So that is the problem. And we have now come up with a call for an establishment of a task force, because when we interacted with the legal professionals, lawyers, and judges, many of them said ritual and witchcraft and things like that, there is no place in the law in Nigeria. And so if you catch somebody for witchcraft, you cannot prosecute the person. So we are thinking of having a task force until our legal system has been upgraded to be able to deal with this cause of gender-based violence. I also want to find out, as women doctors, what can we do when we see that things like control of a pandemic that affects the entire globe gets politicized? Is there a way we can speak out so that our colleagues do not do things just because they are affiliated to or they prefer one political party against another? Thank you.
Thank you for your question. Anybody on the panel would like to address that? Dr. Murthy, any comments?
No, Dr. Keswani, I think thank you. And I really, I mean, it's really great that, oh, there is a question which just popped up. Do I have your permission to read it out, Dr. Keswani?
Go ahead, go ahead.
So this question is from Renu Paswan from India. She says, I am Renu Paswan from India and would like to know how things are in place to spread awareness about women's hygiene in rural parts of the world. Dr. Usha Saraya, you are on the call and you are representing India and as past Vice President of Central Asia. Could you please answer that question?
Am I unmuted? Can you hear
Yes,
me
you
now?
are. Yeah, you are.
Yes,
Please go ahead.
We have a very, very positive attitude towards adolescent girls. We have, government has started adolescent girl clinics in many of the primary health centers and district hospitals, where we gave the girls all the information about menstrual hygiene and how to look after themselves and also how to protect themselves. You know, that is a very important thing. We want our women to be strong. We want them to be able to look after themselves all the time. If their self-image is very low, then people take advantage of the girls. So with education and empowerment and knowledge about their own body system, we are trying very hard to overcome this problem of violence against girls. So the schools are also very, very careful about how they look after the girls, and they have continuous training to the girls about how to become self-reliant and to get the education and empowerment. So I do think a lot is being done for the rural women. They have even been encouraged to go to school and they've been given cycles and things like that to promote better attendance. So first thing is, of course, to get the girls into the school, and then they do get a lot of information. And I hope that answers your question. And you can be sure that better things will happen now for the girls because of the adolescent clinics where they can come and with all their questions and it will be answered. Thank you.
Thank you, Dr. Saraya. Nice to see you on the program.
Nice to see you.
Okay, we have another 6 minutes. Any other questions that I can take? Dr. Casper, I see your name up here.
Yes.
No response? Well, seeing no other questions, Dr. Murthy. Oh, there you are. There you are. Any words of wisdom?
Yes, a few words of wisdom. If you look at the program, so many people are talking about climate, and next year so many are talking about climate. And I think it would be nice if one of the speakers tonight had raised this important issue of the inequality of health for women due to climate. And it's a horrific issue. And I know that next year the CSW will be concentrating on climate. And I believe MWIA should really be getting our knowledge up so that our women doctors across the globe can confidently talk about the issues for climate, for women in healthcare before they face the CSW next year. It'd be nice to have a whole stack of information on our website.
Thank you very much. I hope it can be done. Any other questions from the speakers or the audience? In that case, Dr. Murthy, I think I will give you 4 minutes to wrap up our session. Dr. Murthy.
Thank you so much, Dr. Keswani. First of all, before I thank everybody else, I think on behalf of MWIA and AMBA, we really owe a lot to you for your continued mentorship, your grace and leadership, and encouraging all of us. And for me, especially after my mom passed away, you're like another mother, and I really thank you every day. And can I request somebody to mute their mic, please? Much appreciated. Thank you. And also, I would just like to say a big thank you to the EXCO, MWIA EXCO president, all the vice president, past president, treasurer, for doing everything in such difficult circumstances, and all our women physicians and attendees from far and near who have attended the CSW. I would like to also say that if Dr. Casper wants to talk about the climate thing, which is a great idea, which a lot of us are focusing on, actually, any information you could always share with Marissa Daniels, who is our webmaster from Australia, a young physician who's doing an outstanding job, and send it to her, because she and Dr. Fleiderer if you have not checked out our website, please check it out, because these two people have done a phenomenal job on the updating our website and making it up to time, working alongside the web developer and also the social media committee, who has been constantly posting and monitoring. I just wanted to say that climate is important, yes, but before that, we need to make sure that the fabric of gender equality and gender equity is woven into every SDG, whether it is SDG 3, SDG 5, 17, 1, 2, 4, because unless we start thinking of not he and she, but of us as people, we cannot move forward. And then we have all the climate activists. Yes, we know we are really, the world, we are not paying enough attention to address these. And that's why in the past, MWIA has worked with the International Society of Doctors for the Environment to address these issues. We've had them at past CSWs. You remember that, Dr. Keswani, when we were actually in the United Nations face to face. So that being said, I think when we look at all these issues as women physicians, as global citizens, as I would like to use the term, we need to take a holistic view and just not think that this is the only factor responsible. So it needs to be multifactorial, and that's the way to move forward. And last but not least, Dr. Keswani and myself, it's been really a privilege and an honor to organize this session. And also, we really do thank all of you for your very insightful comments, and all our attendees from Australia, Canada, Nigeria, India, everywhere in the world for your insightful comments. It's really shows that, we can make a difference, because we don't think of me, but we are thinking of the global picture. So that being said, we have exactly a little less than 2 minutes. I'm going to turn it back to Dr. Keswani for her words of wisdom, and then we sign off. And thank you again, everybody. Please enjoy the rest of the CSW. And once this recording is available, because we hope to post it again, it's not our Zoom, it is the Zoom on the Pathable, which is used by the NGO CSW. And thank you again for all your comments, your passion, and please stay safe during COVID. Back to you, Dr. Keswani.
Thank you, Dr. Murthy. It was so beautiful, and you did all the work, and I get all the escalades, huh? Thank you again, personally to you, but I just would like to end by saying that we women physicians ought to bind together and educate the younger ones so that we can continue to go forwards. I feel that we have to look after the younger generation in order for them to continue the work that we are doing. And thank you for your participation, and hope to see you in person in 66 next year, CSW. Bye-bye to all. And
Can
be
we
safe.
turn on our cameras and take a photo before the end, Dr. Kiswani?
Yes.
Okay,
yes.
so Des, you want to
Super.
do
Thanks,
that? We'll
everyone.
put everybody in the gallery mode so that we have everybody. I think we should be in the gallery mode.
I am in the gallery mode. So if
Yes,
everybody
we are.
turns on their cameras, make sure we're not looking up your nose, and I will press the button. Oh, come on, everybody. Quick, some slow pokes there. 5, 4, 3, 2, 1. Cheese.
Cheese.
I've got that, and I'll send that through to you, Dr. Murthy.
Thank you so much for taking that picture from down under, Dr. Yap.
We are on time, and goodbye.
Yes,
till
thank you
then.
so much, Dr. Keswani. A big
Take
namaste
care,
to you.
everyone.
Thank you. Thank you, everybody.
Bye-bye.
Namaste.
Have a
Bye.
Swati,
Stay safe.
Vinny, good to see you, Auntie
Bye,
Lucia.
Bye-bye. Bye, Eleanor.
Bye, everyone.
Bye.
Bye.
Bye, Eleanor.